Welcome. Let's talk about the general recommendations for vasopressor selection in septic shock. These are based on the Surviving Sepsis Campaign guidelines. Today we'll briefly touch on the types of vasopressors used. Next we'll go on and talk about the preference in terms of first line, second line, and third line of vasopressors, the route of administration, and the target goal. Alright, let's get started. The first type, or the most common type, of the number one vasopressor you should consider using is norepinephrine, which is an alpha and beta agonist. It usually starts off at 0.1 mics per kilo per minute, and it goes up to a value of 0.5 mics per kilo per minute. So you want to start that off. If a patient's in shock, for example, and let's say the MAPs are in the 40s or 50s, and then fluoride shock, go ahead and start the presses while resuscitating. These patients don't wait until you've given them at least 2 liters, especially if they're in life-threatening shock. The first line, like I said, is norepinephrine. The next one we'll talk about is dopamine. Dopamine has lost a little bit of its luster in recent years, as they found that it causes more tachyarrhythmias in patients and doesn't have much more benefit than norepinephrine. Dopamine usually is tended to be reserved for patients with bradycardia, and it works pretty well in these patients, along with the fact that dopamine is usually pre-mixed on the crash cart, so it's the first easiest thing to get to. So I wouldn't be a purist about that. If you need presses immediately, you can always start off on that and then wean that off as you're adding on norepinephrine. So those are the first two that, well, norepinephrine is the first line dopamine if you need to, especially if there's an indication for it. The next one you should actually go for, and it's getting back into its popularity, is epinephrine itself. And you should consider using that. Now, when I consider using epinephrine, especially when I realize that norepi doesn't have the desired effect. So instead of adding on dopa, which doesn't really give me any much more bang for my buck, I normally add on norepi. I'll add on epinephrine, especially if I find that norepi is going up at really quick rate, and I'm increasing the doses up to 0.5 mics per kilo per minute, and I'm not getting the response to the map change, desired map change. Now, at that point, I'll choose epinephrine. I'll go for vasopressin if I notice that the increase is more gradual, like I feel like I'm getting some response in terms of the patient map, but not getting enough. I'll add on vasopressin at that point at 0.03 units a minute, and sometimes it's 0.04 as well. So that's the recommended range. I don't try to titrate that up any further. There's been some evidence, at least, in going up a little, increasing it to 0.6 or 0.8, especially as salvage therapy. And you don't want to go up any much higher than that because it does have cardiotoxicity effects. So the first line, like I mentioned, norepinephrine. If you're losing and you're not finding any response, jump to epinephrine. If you're increasing it gradually and you find like you need a little bit more of an adjunctive therapy, add vasopressin. Now I want to stress that vasopressin should not be used as a single pressor. So use it as an adjunct therapy only. The next one, and the one that I generally prefer not to use, is neosynephrine, and this is a pure alpha agonist. How it works is it usually is if you add on like levofed or norepinephrine and you get serious tachyarrhythmias. Now, just because someone's tachy at 110, 120 doesn't mean that adding on levofed is definitely going to cause tachyarrhythmia. Now, you want to make sure that you give them at least some alpha and beta action. The neosynephrine only gives you a pure alpha action. So you should use it for someone who truly has serious tachyarrhythmias, especially if you add on norepinephrine and you find the heart rate burst through the roof, or the patient becomes hemodynamically unstable due to the new tachycardia based on the norepi. And sometimes take note as well that the tachycardia could be driven by the pathophysiology of the septic shock itself. So at that point, adding, increasing, or continuing fluid resuscitation aggressively may attenuate the change in heart rate with norepi being added, so you don't actually have to add on neosynephrine. But the few times that you want to consider adding neosynephrine is one is if you have someone in serious tachyarrhythmias, and that's been proven based on adding on the neosynephrine. The other time I'll consider it is if it's a salvage therapy as well. I've added on levofed or norepinephrine. I've put them on vasopressin. He's not responding to epinephrine, and then I'll add on maybe neosynephrine as a fourth line or third line agent at that point. The other thing you want to also consider using is someone with good cardiac output. And you know that for sure, because if someone's poor cardiac output and if you have a low EF, consider or imagine clamping down on the vasculature so that you increase the afterload pretty dramatically, and they can go into worsening cardiac failure as well. The other time that you want to use neosynephrine is if it's anesthesia-induced hypotension. Neosynephrine works really well. It's used pretty frequently in the OR setting or in the operation theater. The other time that it's also used it's pretty good is in anaphylactic shock and neurogenic shock. Again, knowing full well that the patient has good cardiac output. The route of administration, don't be fooled by the need for central line. So while central line is required, especially for long-term and stability of route of administration, if you're in a bind, a peripheral IV works just as well, especially a 16 or 18 gauge. Another thing that's gaining popularity and needs to gain more commonplace, I guess, in the ER is the interosseous as well. So you can run presses through all of those three routes. The target map should be around above 65, but take note as well that if the patient is peeing or has good urine output of more than 0.5 cc's per kilogram per minute or per hour, at that point you may want to reassess your MAP target so you can wean off some of these presses. So don't just target the MAP blindly, especially if you're on multiple presses. I would advise you or urge you to put them on, have an arterial line placed so you make sure you're not flying blindly. But if you find the target map is just above 65 or let's say 63, and they're peeing really well and the urine output is 0.5 kilo per minute, 0.5 cc's per kilo per minute per hour, you can go ahead and start weaning down and maybe reassess the map target to above 60. So just to recap now, we've talked about the type of presses, we've talked about the preference, which starts off with norepinephrine. Next is epinephrine. If norepi doesn't do anything for your MAP. Vasopressin is adjunct therapy. You may add in dopamine, especially when it's an easy access on the crash carts versus patients with bradycardia. Neosynephrine may be added, especially if you know someone has good cardiac output. The other time you would add it as well as a salvage therapy, or in patients with anesthesia-induced hypotension or anaphylactic or neurogenic shock. So those are the types of situations that you may want to refer, or even when you have tachyarrhythmias as well. That's the time that you want to consider using neosynephrine. The route of administration as well, we spoke about using central lines, even peripheral lines or interosseous devices as well is used, and the target map needed to achieve. So the target map is above 65. Some patients may need slightly higher maps depending on their history of atherosclerotic disease, and some patients may need a lower map based on their urine output if they're perfusing really well. So though the guidelines say above 65, you need to match every patient to their underlying physiology. Thank you.